So as promised from the last video last week, that this week we will be talking about the respiratory complications found in an infant of a diabetic mother and how to manage them. Please stay with me till the end as I take you through them. Welcome to PaedsCrib, where we guide young minds to heal young lives through case-based discussions. I am Dr. Manyesane, a pediatrician based in East London. If you find value in our content, don't forget to subscribe, like, and share with peers. And make sure you hit the bell notification so you never miss an update. Let's dive in and grow together. The causes of respiratory distress in an infant of a diabetic mother can be divided into cardiac and non-cardiac causes. And out of the non-cardiac causes, you can further divide them into respiratory, metabolic, and hematological causes. In the following slides, I'll be taking you through each cause and explaining the pathophysiology underlying it. Please make sure you stay with me till the end so that you don't miss this. So let's start with the cardiac complication. The most common cardiac complication in an infant of a diabetic mother is a HOCM, hypertrophic obstructive cardiomyopathy. These patients have actually been found to have an asymmetrical ventricular septal hypertrophy. It is asymmetrical because it has been found out that it is the left ventricular septum that becomes more hypertrophied than the right ventricular septum. So when this happens, if this left ventricular septum hypertrophies, it actually becomes so thicker that it comes close to the aortic valve, or it narrows the aortic valve, and also it decreases the size of the left ventricle. So if the narrowing of the aortic valve becomes significant, we usually say this causes a left ventricular outflow obstruction. What we mean by that is that the left ventricle is going to be unable to eject all its cardiac output to meet the systemic demands because of the relative aortic stenosis that has been created by this thick septum, which narrows the aortic valve because it thickens towards the aortic valve. Now, how are you going to see such a patient clinically? So because there's decreased cardiac output and therefore systemic perfusion, this is a patient clinically who's going to be very poorly perfused, is going to have prolonged capillary refill times, is going to look pale, is going to have very weak pulses because there's no cardiac output, and the BPs are going to be on the lower side. As we know, BP is equal to cardiac output times total peripheral resistance. So when your cardiac output has been decreased because the left ventricle is unable to eject because of the relative obstruction, it means that will drop your blood pressures. If your blood pressures drop, there will then be a compensatory tachycardia. So this patient will be tachycardic, and when you do your full cardiac examination, on top of the weak pulses, low BPs, poor perfusion, tachycardia, this patient will be in congestive cardiac failure. Now, it is important for us to know the cause of this congestive cardiac failure. The cause of this congestive cardiac failure is due to the back pressure that builds all the way from the left ventricle towards the right side of the heart. So meaning that all the circulation that is coming from the right side of the heart to the left side through the pulmonary veins into the left atrium and therefore left ventricle, the left ventricle is unable to eject all that blood out into the aorta because of this left ventricular outflow obstruction created by this septal hypertrophy. So when that happens, because the volume keeps on coming from the right side of the heart, there's going to be a build-up of pressure in the left ventricle, and that build up of pressure will go backwards. So left ventricle, it will be a back pressure towards the left atrium and therefore towards the pulmonary veins back into the right atrium and into the left ventricle. And if that back pressure reaches the right atrium, as we know that blood coming from deoxygenated blood coming from the system through the superior vena cava and inferior vena cava drains into the right atrium. So if there's a back pressure in the right atrium, it means there will also be a back pressure in the superior vena cava and inferior vena cava. That's why this patient, on top of having left-sided heart failure signs, they will also have signs of right heart failure, that is liver congestions and all. So that is how this heart failure is going to come about. It's important when you're seeing an infant of a diabetic mother who is in severe respiratory distress to do a thorough examination of the cardiac system, looking for signs of an obstructive hypertrophic cardiomyopathy, because this becomes an emergency. Please stay with me as I tell you how we then manage this kind of a cardiac failure. So the pathophysiology that I've just mentioned here becomes very important, especially when you need to take this patient out of congestive cardiac failure, because the cardiac failure that this particular patient will be having is not the same as the congestive cardiac failure that we usually see in other cardiac patients, where they have too much preload. Because when the patient is having too much preload or is fluidly overloaded, that's when you need to diurese the patients. But this particular patient actually has decreased ventricular filling. Why? Because of the back pressure that goes all the way to the right side of the heart, especially the right atrium. It means the inferior vena cava and the superior vena cava are unable to drain all the blood that they have taken from the systemic circulation back into the heart. Reason for this is because there's also increased pressures on in the right atrium, so they are unable to drain back into the right atrium because of the increased pressures. Hence, these patients will have hepatomegaly and they will have dilated neck veins. It's because of that. So meaning that the way to treat the cardiac failure of this patient is to deal with the back pressure. So how do we deal with this back pressure? The first line of treatment in this patient is to give beta blockers. This patient, depending on the severity of the left ventricular outflow obstruction, they may actually need very high doses, and they can actually need infusions of IV infusions of beta blockers. What do we want beta blockers to do? We want the beta blockers to relax the left ventricle and to decrease that heart rate. Remember, the lower the heart rate is, the more time the left ventricle is going to have to fill during diastole. So if you allow the left ventricle to fill in as much as possible, it means relaxing it creates more space or more room in the left ventricle. And when you create more room, that means the pressure is going to drop, because radius is indirectly proportional to pressure. The minute your radius increases, it means your pressure will decrease. That's what we're trying to create here. So beta blockers are the mainstay of treatment, because as the pressure decreases in the left ventricle, it means also the back pressure will eventually decrease, and therefore the effects that back pressure has caused will also eventually disappear. Now, in neonates, if this left ventricular outflow obstruction, it is so severe that it causes systemic circulatory failure and severe congestive cardiac failure, then this becomes a duct-dependent lesion. What do we mean by that? It means this lesion will depend on us opening the PDA. Why do we want to open the PDA? Normally, the PDA causes a left to right shunt, but in this case, we want it to do the opposite. We want it to cause a right to left shunt. We want to steal some of the blood in the pulmonary circulation into the aorta. And this will become possible because right now the right-sided pressures are actually on the higher side because of the back pressure that has been created all the way from the left ventricle. So the blood in the PDA that we will open using a prostin will steal blood from the pulmonary circulation into the aorta, and therefore we will add some form of systemic perfusion. I hope that makes sense. So that is how we treat this heart failure in this patient. Lasix is contraindicated in this particular patient. Now moving on to the respiratory system causes of respiratory distress in an IDM. So these patients can actually have TTN because most of them, because they are large for gestational age babies, they actually undergo cesarean section, which all of these put these patients at risk of having transient tachypnea of the newborn. So this is a self-limiting condition which usually resolves within 6 hours of birth. They don't usually need anything other than close monitoring, some IV fluids. Sometimes they can need a bit of CPAP, but eventually they will be out of oxygen in no time. The second cause of a respiratory system cause of respiratory distress in this patient, it might be HMD. As I've mentioned in the last video, that these patients, even though they are usually large for gestational age, but they are relatively premature. They are large because of the anabolic effects of the insulin. So if it is a premature baby, it means these patients can have premature complications of the respiratory system like HMD. So they can have surfactant deficiency that any preterm baby might have, causing HMD. On top of that, the hyperinsulinemia that these patients have antagonizes cortisol because insulin has counter-regulatory hormones like cortisol, growth hormone, glucagon, and epinephrine. So when insulin is high, it means it inhibits those hormones, especially the cortisol. In this case, you need the cortisol to help in the synthesis of surfactant. So it means that will further worsen the increased risk of HMD in these patients. Now, if you suspect HMD in this patient has got a severe kind of a respiratory distress and you confirm your HMD radiologically, this is a patient who's going to need surfactant and to be put on CPAP. Even though he's big, but if he has HMD because he's relatively premature and the surfactant has been deactivated by the hyperinsulinemia, this patient will need surfactant, fluid management, and to be put on CPAP. That's how you would treat the respiratory causes of distress in an IDM. Looking at the metabolic causes of respiratory distress in infants of a diabetic mother, hypoglycemia is high on the list. Now, the way hypoglycemia causes respiratory distress in an infant of a diabetic mother is one, by decreasing surfactant production. Now, if you look at the constituents of the surfactant, you'll find out 90% of the surfactant is made of phospholipids and 10% is made of protein. And one of the important phospholipids is the palmitoyl diphosphatidylcholine. Now, hypoglycemia inhibits the choline part of that palmitoyl diphosphatidylcholine. And if that choline is inhibited by hypoglycemia, it means you will be unable, the neonate will be unable to form the main part of the phospholipids and therefore the main part of surfactant production. So that is how hypoglycemia inhibits a surfactant production, by inhibiting the choline part of that phospholipid. Secondly, when you have hypoglycemia, we did say that there will be stimulation of the 4 counter-regulatory hormones, which is cortisol, glucagon, growth hormone, and epinephrine. Epinephrine is a potent vasoconstrictor. So hypoglycemia can indirectly cause vasoconstriction through the release of that counter-regulatory hormone, epinephrine. And if there's vasoconstriction, it means there can be decreased perfusion into the lungs, which will then eventually lead to respiratory distress. So those are some of the metabolic causes of respiratory distress in an infant of a diabetic mother. So how you manage it is that you treat the hypoglycemia how we have discussed it before. Lastly, the hematological causes of respiratory distress in an infant of a diabetic mother. So we did say that infant of diabetic mothers are at risk of polycythemia, and we did say that this is because of the maternal renovascular diseases that will cause placental insufficiency and therefore hypoxia to the fetus. And the fetus response to the hypoxia, the kidneys of the fetus will release erythropoietin, which will then stimulate red blood cell production, and this infant will have polycythemia. So polycythemia causes hyperviscosity of blood and therefore sluggish circulation. And if the sluggish circulation, it means there can be decreased pulmonary perfusion, which will then lead to respiratory distress. So these are the causes of respiratory distress in an infant of a diabetic mother.